Welcome back. I'm Tracy Swinburne with the VBID Center. I hope you all enjoyed your lunch. And as we start our afternoon session, we'll start with a session on implementation. So first I wanted to share with you our latest resource that we've developed at the VBID Center. We wanted to tell you about our new VBID registry. Dean Filbert mentioned this morning. This is our new tool that will be an opportunity for you to help contribute and let us know about your VBID experiments, your VBID plans, VBID programs, and put them online in this web-based registry. And then it'll be a chance, once we've compiled this information together, people can search the registry for VBID plans. You can search it by geography, by state. We'll have some international programs, we hope. You can search it by disease state or by keywords. So this will be a chance to share the best of the case studies and the examples that we know about. We recognize that one of the key elements of improving implementation is to share what we know, to share what people are doing. And we hope this will be essentially a really effective, really valuable case study collection that you can search through and find examples that are most relevant to you, most relevant to what you're looking for. So we hope that you'll visit our registry. It's at vbidregistry.org. We're launching it today. We're really delighted about it, and we really can use your help. Please help us in implementing examples so that we can share with others and we can help grow on the innovation that's going on in implementation. So with that, I'm going to hand it over to Andy Chasen, who's going to moderate our implementation session. Thanks very much. Thanks, Andy.
Thank you. I think the only thing tougher than following Senator Daschle is following lunch, but we will do our best. So my name is Andy Chasen, and it really is a great pleasure for me to be here and moderate this panel on implementation of VBID designs. By way of introduction, I met Mark Fendrick and Mike Chernew when I was working on the Hill, and together through the power of a good idea and a lot of good luck, we were able to get VBID into the Affordable Care Act. And since then, we've had great success on the regulatory front. We were able to have regulations implementing Section 2713, which is the Preventive Services section, which we haven't really even talked about today, with really positive mentions about VBID. The recent IOM report on essential benefits has very positive statements about value-based insurance design and the need to move the delivery system to higher value care. And not sure many of you know this, but last week Dr. Fendrick testified in front of the Senate Help Committee about delivery system reform, and VBID was one of the featured subjects of that hearing. So you feel that in the policy arena we've really reached a tipping point on VBID, and you're starting to see the same thing in among private plans. So, and I think it follows from, we had Newt Gingrich and Debbie Stabenow both supporting us on the policy front. So if you have those two together, you've got to be doing something right. So following my time on the Hill, I actually moved to Blue Shield of California, and I've managed to stay involved with VBID with a new project that I'm really excited about, and that is Blue Shield of California, my current employer, recently launched a new plan called Blue Groove with Mark Fendrick's clinical help. Don't judge it by its name. Maybe we should have called it peanut butter and jelly, and it would have more success in the market. But we think it's a model of what a health plan of the future really could look like. So it combines a wellness program, member engagement, value-based insurance design, and high-performing providers. We start with a base plan, and if you participate in a wellness program and a biometric screening, you move into a richer product tied to our successful ACO with a cash incentive provided to you, mixing a lot of the things we've already talked about here today. And here's the part that I think is really neat and groundbreaking and that Mark really helped us with. And that's if during the wellness screening you're identified as having one of 6 chronic conditions, you move to a care groove, which is a VBID design where you participate in a care-coordinated medical home. And we will remove the barriers to your needed valuable services. So the goal here is obviously to get the people with these chronic conditions the care they need and to avoid high expenses. So this is definitely a learning opportunity for us, and we hope to refine it over time, but hopefully it will provide even more evidence to demonstrate the value of VBID in the market. Today we have presenters who can tell you in much more detail their experiences of putting VBID plans in place. We have a really terrific panel. Someone described them as overqualified, and I think as you hear their resumes, you will agree. So they're going to help us understand some of the opportunities and challenges. First, Peggy O'Kane is the president of the National Committee of Quality Assurance, or NCQA, as we all know it. Under her leadership, NCQA has developed broad support among the consumer, employer, and health plan communities. NCQA and HEDIS data have become the benchmark for evaluating quality. And as you see standards for quality comparisons of plans in the exchange developed, I have no doubt that NCQA metrics will certainly be at the forefront of those measures. David Grossman, a practicing pediatrician, is currently a senior investigator at the Group Health Research Institute and the medical director for preventive care at Group Health Cooperative in Seattle. He is also a professor of health services and adjunct professor of pediatrics at the University of Washington. He assisted in the development of Group Health's VBID plan and is now evaluating its impacts on health and productivity. In his free time, he serves on the U.S. Preventive Services Task Force, which, as you all know, has a major role in determining the coverage that is provided under health reform. And Robert Krish is the chief health negotiator for a coalition of labor unions in Connecticut, representing approximately 50,000 employees. He co-chairs a joint labor management committee that oversees and administers a self-insured health care plan for active and retired Connecticut state employees with 225,000 covered lives. I think the story of Connecticut is so interesting because adopting a VBID plan ended up being one of the ways the governor and the union settled negotiation over health spending. And with all the tension you see across the country with states trying to deal with budgets, it really may represent a new and exciting path forward. So with that, I'll turn it over to Peggy.
Thank you, Andy. That's a very nice introduction. I'm really excited to hear about your new product. I think my major message today is it's a bundle. It's not just VBID, it's not just medical home or ACOs. It's a whole list of policy interventions that really we need to create synergy among. Okay. I have slides, but I'm going to start just with some remarks. First of all, congratulations on a fantastic program. So what is NCQA doing talking about benefits? We're the quality people, right? I think the more I see of what's going on, I think the more I understand that we're like a house on fire, and it's about costs, and costs actually undermine our ability to deliver high-quality care. I think that the default position that we have is the high deductible, and I think that is non-value-based benefit design, insurance design. So let me just tell you a little story that really brought this home for me. I was in Colorado at a Beacon community, and there were medical homes, and there were people doing great things with electronic medical records, and the community's wiring it all up. And then the teachers, the school district stood up and said, this is all very interesting, but we can't bear these costs anymore, and so we're putting in a $5,900 deductible next year for a family plan. And think about what that does to everything that the delivery system is trying to do to deliver better value. And I think this kind of illustrates why this is such an urgent agenda, and we don't have time to fool around. We need to get moving with it. The other thing I wanted to tell you is that we are releasing our Accountable Care Organization standards on Monday. We'd encourage you all to go online and look at that. I'm not going to talk about that today. We just did a press briefing. I think we're moving into a new world. I don't know about ACOs, but I think between ACOs and the incredible things that people are doing with patient-centered medical homes and other delivery system reforms, we're in a new era. And so now we need to get, I think Alan's presentation this morning was really great about creating this synergy between the incentives that the providers now are facing and the incentives that consumers will face more and more in the future. So it's not easy. It's not going to be possible to do randomized clinical trials of single interventions. And, I think those days are kind of past and good riddance, because I don't think this is the way the world works. So let's get busy and let's evaluate the outcomes. Let's have learning networks that are trying to do some combination of these things, and let's have the health services researchers help us figure out a good way of evaluating these projects, but we need to move. Often I think about, I've been in my job for 21 years, and I think, are we better off now or are we worse off? And I think the one way in which we're better off is that we know a lot more about where the opportunities are and the urgency of action. And so we need to act on that. NCQA, of course, we're all about measurement and evidence-based care. And I guess Mark seemed to think that somehow we were going to be making announcements about value-based insurance. He says no. Anyway, we do make a lot of judgments about evidence in the course of doing our measurement work. That itself is not easy. I think that the point that somebody needs to be let me talk about this first, but I'll get to it. So I think, how many of you know about NCQA? I don't probably need to talk about this. Okay, forget it. And I also wanted to call out my congratulations to the Essential Health Benefits Committee at the IOM. I think most of you have seen this. I hope you've read the summary, at least, of the report. This is an act of courage, and the wonderful people, I should add, that sat on that group deserve a lot of credit for a very nuanced and public service-minded approach, and they really understood that we have to be rigorous about essential health benefits and about coverage if we're going to be able to afford health insurance in the future, and they put it that starkly. And I think that the report really reinforces the importance of evidence and understands the importance of trade-offs, and even is encouraging the use of some of the community outreach methods that were used with the Oregon Health Plan. So I think it stands as a landmark in my mind among the works that the IOM has published, and I just want to say hats off. It's really great. NCQA now has HEDIS data annually on the quality of care for 118 million Americans, most of whom are in plans that we accredit. And that hasn't been an easy agenda, but I think we feel very proud of it. But it's an incomplete agenda in about every way I can think of. We do have to make judgments about what we're going to have measures about, and we are particularly concerned not to be measuring things that aren't valuable. So if it doesn't add to people's health, we don't want to measure it, because measurement, if it is actually put into a robust accountability agenda, it will drive people to do things, and we don't want to drive people to do things that really aren't that good. In the course of doing our measurement work, we have had to make a lot of calls because, we have many different groups doing guidelines. There are many areas of clinical controversy. And I do think that there is a need for somebody to be trying to not have everybody do one-offs on what is value-based insurance design. I do think that there is a need for, maybe with PCORI or maybe with some of the results of PCORI, to really start to put out some guidance, and maybe this is something that your group could do. It is going to have to be consensus-based. It is going to have to work with incomplete information. But I think, moving beyond the tiered pharmacy benefit is something that's really important. So I really want to make a plea for that. This is a picture from Jack Wenberg's latest group, and this shows how we spend our Medicare dollars, and we probably have a similar distribution for our private health insurance and Medicaid. The slices may be different. But in Medicare dollars, he attributes about 15% of that spend to effective care, and that's, of course, the stuff that we want to have really good coverage for. And, as we have these high deductible plans out there, and somebody pointed out this morning that the exchanges actually have pretty high deductibles for the kind of people that are going to be shopping with them, we need to be very careful to pull out things from the deductible that need to be covered, or we're going to wind up shooting ourselves in the foot. Preference-sensitive care, Wenberg says, is about 25% of our spend. So I think we need to get into that, and shared decision-making, I believe, should be a standard part of the value-based insurance design agenda. And then there's supply-sensitive care, and how we go after that, I think This is not necessarily a value-based insurance design question, but it needs to be crosswalked with it. So if there's a lot of churning of particular services, and you can look at the Dartmouth Atlas and see what goes on, there has to be a way of saying this much and not that much, or maybe having declining coverage for things that are typically overutilized. So I think this goes beyond, is it valuable, and if it's valuable you get full coverage, and if it's less valuable you get less coverage, and so on. Prices, of course, are the other big issue out there, and that has to be addressed as well. And I think that there are some experiments going on with reference pricing that I think we need to pay attention to and do more of. So when I think about value-based insurance design, I do think broadly, and I do think it is this bundle. So that would be the thing I'd like you to walk away with from my talk today. So tiered pharmacy, reference pricing. Reference pricing is tricky if you don't know about the quality of the various alternatives, and Mark and I had a good discussion about this. But we're going to have more and more quality information out there, and we need to, for some things, I think it is kind of a, if you're getting a lab test from here or a lab test from there, and this one costs $15 and that one costs $45, there's no reason in the world that the insurance should pick up that differential, in my mind. Free evidence-based benefits, preventive services. Tobacco cessation, I think we've seen great examples of how that really does help. Shared decision-making, I made the pitch already. I'm on the board of the Foundation for Informed Medical Decision-Making. We need to get this out there much more than it is today. We need to get the doctors bought into it, probably the primary care doctors, I think. It's kind of a hard sell to the specialist that may be adversely impacted if somebody, with the full information, decides not to get the procedure. The most favored people in the delivery system is the other piece of the agenda. So as people are doing really interesting things, we just yesterday had Richard Popeil from Horizon Blue Cross in New Jersey in. They're building off a patient-centered medical home model, among many other things that they're doing. And they are really creating accountable kind of pools of doctors. We'll be giving them a lot of information and a lot of coaching, embedding care managers. So the patient-centered medical home was one building block, but we're watching people do amazing things moving beyond that. And there should be incentives for people to go to, when you can have a piece of the delivery system that delivers quality, affordable health care, there's nothing wrong with having an incentive, in my mind, for consumers to go there. And participation in chronic disease management. So whatever it is, we need to have patient engagement and patient activation, and I don't think we should be shy about asking patients to do things that are actually in their self-interest, as long as we don't punish the people that really have no choice or aren't able to do whatever it is, and get to the outcome. So ACOs, I think, could be a good vehicle. I think the jury's out on ACOs, whether this is ever going to really take off, I think. If you look at the prepaid group practice demonstration that CMS did, which is going to be many of the early ACOs, I can't remember how many there were, 14 or 15, I think. There were 2 that made money. One was here, but I gather it wasn't that much. And the one that really made money was Marshfield. And I won't comment on that because I heard they were making money on other areas too. But Marshfield was one of the few that didn't have a hospital. And so I think as ACOs roll out, we're going to have different entities that are really driving this. And where it's a hospital, I feel like we've been through this, or I've been to this movie before, because I've been around long enough to remember PHOs, hospital-based HMOs, and it is the rare hospital that really is ready to embrace this completely flipped paradigm of a business model. So I think we all need to welcome the hospital that does that, but I think we also need to not put our eggs all in one basket. I think there are going to be a variety of different things happening. I just also wanted to point out, how many of you are familiar with Oregon's value-based insurance design? Anybody? Yeah, we've had them come and speak at our policy conference last year, and I thought they really had gone a long way in terms of thinking about comprehensively about what they're covering. So they have free preventive services, and I guess it was their data I saw that with their free coverage of smoking cessation, they've brought their smoking rate down. I don't remember the numbers, maybe from 20% to 14%, but noticeable. They have lower copays for going to a patient-centered medical home. They are trying to really engage their members, and this is, I guess this is the employees of the state of Oregon and Medicaid. I think that's right. And they're doing a lot of communication. And they looked at their own use patterns, and this is another important point. It so happened in Oregon, sleep therapy or sleep studies were a big deal. There were a lot of them going on. There were a lot of patients getting studied. There was no follow-up, or there was no treatment, leading to the conclusion that maybe the study wasn't needed in the first place. So they cut their reimbursement for that very dramatically. They excluded cancer and emergency treatment. I think emergency treatment, not use of emergency rooms. So we have lessons out there. I congratulate the Center for Value-Based Insurance Design on their new project. I hope you'll get the word out. I hope you'll look at combinations of interventions. I really applaud you for the wonderful work. This is such an important piece of the agenda, and we can't do the rest of it without it. So thank you so much, and I look forward to the discussion afterwards.
Afternoon, everyone. Thanks. Since you can't move and you're locked in your seat, I thought I'd give you a little vicarious motion here. Actually, this is a group health meeting. We actually do incent, as part of our wellness program, people to go out and actually exercise while they meet and actually reward them with points for that. So it's very common to see group health people moving in the city, walking in groups, probably usually not greater than 3, in doing moving meetings. But I'm not sure that anyone's tried biking and meeting. Just a few words. I'm going to tell you a little bit about our VBID plan that we've done at Group Health, and just a few words about the research evaluation that we're doing as well. Just a quick few words about Group Health. Some of you may be familiar with us in that lonely corner of the Northwest. We are a healthcare system, we're a health plan, and we're also an employer. My perspective today that I'm going to be offering to you is really as employer. But just since our employees interact with our healthcare system, just a few words there. We're a consumer-governed nonprofit, about 670,000 members, and our members receive care in 26 medical centers, all of which are certified medical homes and also are all electronic. We have over 9,000 employees and 1,200 medical staff members, and I'll tell you a little bit more about the plan as we go through this. So I think I'm going to skip this piece because I think we've covered this. Let me just say that the impetus for Group Health's value-based plan, which we call Total Health, was really the idea of our CEO, who really wanted to take a different approach with our employees, not only in terms of health benefits, but also labor relations. And just wanted to rethink the whole way in which we engage our staff in the way they do their work, and the way they engage our customers. And health benefits was a part of that whole picture. It wasn't just in isolation. So the Group Health Human Resources developed a set of aims around the value-based insurance design, which was really, and the evaluation as because I wear 2 hats, I was wearing one eye looking at helping them as a medical director and the other eye thinking of this as a researcher. But really their stated aim was to improve productivity through better health of staff, decreased absences and on-the-job productivity that was mentioned earlier as being key outcomes, and they were key outcomes to our employer, Group Health, to decrease the health expenditure trend rate. So the process by which we do that would be to incent healthy behaviors and chronic disease control through a system of incentives, but also to reinforce that culture of self-awareness and accountability. Now, really what was happening was, over the previous 3 to 4 years, we had developed a corporate wellness program, similar to ones that many organizations offer, that had been steadily introducing the concept of accountability and incentives and encouragement and working with small groups in the organization to improve engagement as a prelude to actually this. So we had actually been on the path for about 3 or 4 years prior to coming to this. And it was only when we decided to add the VBID component to this that we decided to really wrap the wellness together with the VBID in a very explicit way. So one of the comments that's been made several times is the importance of the interaction of a VBID plan with the delivery system that people actually intersect with. And I can't help but think that in Group Health, because of our delivery system, although some of our employees have a different plan that allow them to go outside our system, most of them, the vast majority, well over 85% to 90%, use our system for their care. But I can't help but think that it's critically important that it be built on a platform of a medical home, in part so that benefits actually can be consumed in a way that people will be both incented to receive them, but also make it easy for them to receive it. And for which the incentives for our medical staff, which are rewarded on the basis of how well they take care of their population and not on their productivity, align very nicely with these. So that interaction, I think, is a key part of the context. The framework is, I think, not too striking in many ways, but it does start with the invitation to take health risk assessment for all. And that's really, there's a fairly significant financial incentive there, about $400 to $500. It's increasing over time, about $400 to $500 for our staff. They can opt out, but we use the HRA as a means to, like many organizations, many corporations, to understand what the underlying health risks are in the population. And then to have Total Health VBID plan interact with those so that we engage people and make it easier for them to get those services. We focus obviously both on healthy people for reduction of lifestyle risks, but also improvement of chronic disease management. The process by which this whole thing got planned was an interesting one. And what happened was there was a cross-functional design team that it was led by human resources, that brought in health plan product staff and operations staff, actuaries, of course, and then the medical staff were actually very deeply involved in this. We had no less than 4 physicians involved in planning this and thinking through this and what clinically made sense. We also had Research Institute staff, and then we had external consultants who also gave us some norming and benchmarking that was helpful to us. We also, of course, used the center here, the center here and the resources from there, what they had learned before as key resources for us. So I want to assure you as a physician, when I go around, I don't actually do a close inspection about someone's insurance. And if you can't read this in the back, this patient has a rare form of medical insurance. But in fact, our CEO actually asked that cross-functional team to say, I want you to think about something outside of the box, a little bit way beyond the tiered benefit in pharmacy, actually way beyond thinking about just pharmacy in general and thinking about the big picture. In a sense, what Peggy was talking about, the bundled picture. And in fact, I want it to be so it, in fact, would be relatively rare, at least at the outset. So we had that charge about what would VBID version 2.0 look like, and we were allowed to do a lot of blue sky thinking. I want to say that we brought in organized labor at the beginning and involved them deeply, and in particular, several of the unions actually were very, very helpful and I think very supportive of it. There are some key questions that were asked repeatedly, one of which, and has not been mentioned yet, is that your ability of your claim system to adjudicate highly specific claims is really a big issue. And for us, it was too. We had a rather old generation claim system that we're replacing now. But this repeatedly came back as, could a claim system actually pick out this situation? So was it compliant with state requirements? And then finally, the actuaries are, of course, doing all their calculations in the background, wondering what this was going to do to group health resources, human resources budget. So that there was unions all came together in a benefits coalition. We didn't do it one-offs, we did it together. Our labor negotiator, Mike Harrington, is absolutely outstanding, and he engaged them in a way that I think was highly constructive, invited feedback ideas. They got the chance to repeatedly react to drafts, give input on specifics that were considered back by the larger group. So feedback were specific, where we sought specific advice was on cost-free services, and we really wanted to push the issue of increased cost shares for low-value services. We felt that that was important, that VBID was not just about giveaways and dropping and pharmacy copay drops, but really around identifying what those low-value services are. And then they got very involved in the incentive point distribution. They got really involved and really wanted a lot of say about that as well. The other important thing is we bargained the same benefit package for all unions with the same contract date. That had not been, they all had staggered dates, they were all malaligned, they all had different benefit plans, and we took wages and benefits out separately, and benefits were all negotiated together, and wages were taken out separate. So, in fact, the wages still stay on a staggered, but benefits all came together with all the unions together. So what is our design? Really run through that real quick. We already had first dollar coverage for preventive services before ACA, so this was not really an issue for us. But chronic disease cost sharing decreased, both for medications. We introduced the concept of copay plan care visits for chronic disease, and then also cost-free devices for monitoring chronic disease. In addition to that, we also then amped up our worksite wellness and health promotion activities. And as I mentioned, what we did is we said, if you agree to participate, then we will stabilize your premium for, as was negotiated with the unions, up to 3 years, meaning no flat premiums for 3 years, provided you engage, at a premium offset of somewhere between $400 and $500 a year. Now, I'm not sure we followed the right rules like Kevin Volpe. I'm not sure Kevin Volpe would totally approve of what we did, but we'll talk about that later. There was a health risk assessment annual that had to be done annually, but whether you took the HRA did not really have anything to do with your cost share structure. It only had to do with your premium offset. We also made points aimed at heavily at healthy and chronically ill staff. So we got a lot of feedback from staff about health maintenance and the importance of challenging people to improve their health. Challenge me to make me even healthier, and don't just challenge the chronically ill people to get better. And then finally, we invited spouse participation, and we had watched King County go through this process, and we learned quite a bit from them about how to do that. We had a waiver of copay for 2 visits per year for chronic care for these conditions. And for mental health, we included actually 10 visits. We felt very strongly that mental health was such an important component of chronic disease control, and if you've been following the literature on collaborative care and understanding the interaction, is that it's hard to talk about chronic care control without talking about depression. And then finally, we introduced some other, what we thought were relatively novel ideas, is decreasing cost shares for chemical dependency. In other words, try to make the barrier as low as possible for people to get engaged, and also lactation service visits. We reduced copayments to 0 for generic and mail dispense meds because we wanted to drive people to pharmacy warehouse and away from retail meaning our own retail, in part because of efficiencies and for many reasons it's actually a much better experience for patients. And we also, as was talked about earlier, we did decrease copays for brand name drugs as well. It fell in the same categories for those diseases, provided they were listed on our formulary. We also waived cost shares for home blood pressure monitors, diabetic glucose monitors, and spacers for inhaled asthma meds, with the idea that they are important to the delivery of medications and monitoring of care, and there's no reason why patients should have to be paying for those either. So then came the negotiation about the stick, and there was quite a bit of go back and forth, and I didn't participate in all the negotiations about that, but we ended up with a couple things. One is we introduced the outpatient surgery copay. It was a very, very modest copay, and seemingly considering the cost of outpatient surgery relative to medical management for many conditions seemed a reasonable thing to do. A harder thing to do was increase the cost for high-end imaging, and we did introduce new cost shares that previously been zero for MR and CT to reflect the true cost of those procedures, and also to insert a pause into the discussion about the need, and as well to align the fact that we were doing physician incentives to reduce high-end imaging use in our own population, so the physicians were also coming under a fair amount of pressure to reduce what had been a fairly dramatic rise, as we had documented in a Health Affairs article, in our own high-end imaging use. So there was an alignment there. And then finally, we introduced a higher emergency copay visit as we introduced 24-hour urgent care in all of our facilities, with the idea that there shouldn't really, we really wanted to discourage discretionary ER use. So let me just say a word about the design of the study, and I'll be done. We were very lucky. We used some early money, seed money, to actually get the evaluation for this going, because we had a good sense as to where this was happening. I want to say that this is a real-world evaluation. In fact, although the researchers were consultants, they did not dictate the design. This is not a randomized trial. This is a real-world thing that's happening, but much like we did with our evaluation of our medical home, it was an ideal opportunity to do a controlled natural experiment. So we were able, very fortunately, to get a grant from AHRQ, Agency for Healthcare Research Quality, for 4 years to actually study the outcomes of this. So it's a quasi-experimental group, and we were also extremely fortunate that our cousins in Kaiser, Colorado, agreed to be our control group. So in a very, very admirable fashion, and for another learning healthcare organization, they said, yeah, we'll participate with you, and their Institute for Health Research are co-investigators with us, and we really want to learn with you so that we can make intelligent decisions down the road. The research aims are to assess the impact of new value-based design, and I want to emphasize, Mark asked me if I would be real clear on what these aims were, so that you could see that what we're really primarily looking at is health status and workplace productivity. You'll notice that costs and utilization are actually on the secondary aims. They're not top of because we believe that the combination of this is likely to show much greater, and in fact, when you do the statistical power calculations, power actually is quite convincing for our sample size, which is 10,000 people in the intervention group, that we should be able to demonstrate an impact on productivity. So I think I'll leave it there, and then we can talk a little bit more if you're interested. Thanks.
Hi, I just want to say how happy I am to be here to share with you the Connecticut experience on behalf of my colleagues back at the state of Connecticut and the Connecticut State Employee Unions, and tell you about how we got to where we got to and what challenges lie ahead of us. I also want to say that this symposium it's my hope it'll lead to greater health for Connecticut workers and all workers across the country as we explore the possibilities of VBID and better health and lower costs. So I'm going to speak to you from the labor union perspective because I served as the negotiator for the Coalition of Unions on healthcare, but I was also at the table during the negotiations over wages and pension changes because this VBID plan came about in a certain critical fiscal crisis, and I think that had an effect on what we wound up with. So I want to start with just who's covered, and who's covered are the active state employees of about 50,000 and retirees after October 1st, 2011. So we exempted all of the current retirees. It was just too difficult to find a way to engage them in this process, to even reach them, or even to figure out how we would touch them. And also, October 1 was a key date because there were certain pension changes that were taking effect that were deleterious to the existing pension plan. So state employees had a chance to retire with their old benefits, and 4,000 of them did. And so we keyed the future application of VBID to those people who retired after October 1st. So, where did it come from? And where it came from was a fiscal crisis in the state of Connecticut of really unprecedented proportions. There was a $4.6 billion structural deficit for FY12 and a $4.6 billion structural deficit for FY13, and a new governor just elected, a Democrat, the first Democratic governor in 20 years. And when he put out his budget plan in January of 2011, it included tax increases, both sales and income tax, service cuts, and much to our surprise, $2 billion worth of labor concessions. That resulted in some very fast scrambling and the commencement of some very intense negotiations in February of 2011, which revolved around wages, pensions, and health care. And what actually occurred during the other parts of the negotiations, I want to focus on the wages, was that eventually all the state employees wound up with the same wage package. It wasn't like group health. We were just doing health. We were doing wages, pensions, and health care simultaneously. So the negotiations were almost round the clock from February till June. So the wage component wound up of a 0% wage increase, a 0% wage increase, and then a series of 5% wage increases over the next 3 years. So 0, 0, 5, 5, 5, and 4 years of job security. So with that backdrop, we had to fill in the rest of the blanks on the money. And for the healthcare part, what we did was we compromised between the traditional employer proposals to shift costs and the union's coalition's proposals to institute the VBID plan. And what it resulted in this health enhancement overview. This is what happened. After we spoke long and hard about preventive care and screening for chronic conditions, and the employer was stressing higher employee premium co-shares, higher co-pays, higher deductibles, and the like, the eventual program came down to this. During an open enrollment period in August and September, employees had a chance to sign a contract to participate in the VBID program, and they would agree that they would adhere to a certain set of physical examinations for themselves and their dependents. They agreed that they would participate in screenings that had to do with, as I've outlined below, clinical breast exams, cervical screenings, colorectal screenings, according to the schedules. And it also required them, if they were diagnosed with one of the 5 chronic disease conditions, to participate in a disease counseling program that would be carried out through our 2 carriers, Anthem and United. So that was the health enhancement program. That's what you signed up for. That's what you got an opportunity to sign up for, or not. You could stay with your current health plan design, or you could join VBID. Now, as we've seen, VBID comes in many shapes and sizes, and these are the carrots. So if you joined the HEP program, which we had to change the name, people didn't like value-based insurance design, so we changed it to the Health Enhancement Program. It went over very well, quite frankly. Your premium stayed flat for this upcoming year. The prescription co-payments for diabetes were waived. The prescription co-pays for drugs prescribed for all the other chronic conditions were reduced to $0, $5, and $12.50. If you went to your doctor for visits for treatment of those conditions or monitoring, they were free. You were entitled to 2 free dental cleanings per year. We had a lot of conversations around oral health as being a prime indicator of other health conditions. And we lifted the cap on periodontal services. And we had one other carrot, which is not on the slide, and that carrot is if you're in a chronic disease state and you adhered to your medication and you visited your doctor, at the end of the year you would get a check for $100 because you had successfully fulfilled that portion of the program. What also occurred, on the other hand, were the sticks, and there weren't many of them, and they turned out to be pretty big. The state of Connecticut eventually came to buy into the value-based program, but had two demands. One, that if you didn't join, you paid an extra $100 a month in premiums, depending on your class of coverage, and you also had to pay an annual $350 deductible per person with the $1,400 limit for families. And along with that, we did some other plan design changes, and these applied regardless of whether you chose HEP or not. And these really came about as a mixture of looking at our plan and a desire to ramp up the savings. And I'll talk about the savings numbers in a minute. So we had a $0 emergency room copay. The data showed it was really an issue for us. People were using the emergency room as their PCP. We instituted a very modest $35 emergency room copay. We took the pharmacy program for maintenance medications and turned it into a mandatory mail order program for actives and retirees under 65. And so the co-payments there are $5, $10, and $25. We also put in a voluntary mail order for retirees 65 and over, and if they participate, they have zero co-pays for their maintenance medications. We also put in sort of a safety net to the mandatory mail order because a lot of people like to go to the pharmacy. So we worked it out with CVS Caremark, who's our PBM, that you could go and get your mandatory mail order at the pharmacy. That developed into quite a scene because everybody else said, I want my pharmacist, I want to go here, I want to go there. So we had to negotiate with Caremark, and they begrudgingly said, well, okay, if they'll accept certain parameters around the contract, cost items, dispensing fees. Most of the big ones have joined, Stop and Shop, Walmart, and some independents. So we've got a mandatory mail order program where we expect that 85% of it's going to get filled at a pharmacy, but that's collective bargaining for you. We also took the pharmacy copays for active and retirees after October 1st, 2011 for non-maintenance drugs up from $5, $10, $25 to $5, $20, $35 for more cost savings. And we also agreed that our Joint Labor Management Committee would maximize the use of patient-centered medical homes, which we began about 1.5 years ago. And we're trying to ramp that up because we see a lot of promise in the patient-centered medical homes. So we found ourselves in a horrible fiscal crisis. We were in the midst of a 20-year health care agreement. The state of Connecticut in 1997 signed a contract with its unions for a 20-year pension and health care agreement from 1997 to 2017 for reasons I'm really not going to want to go into. But along the way, the unions were trying to open the contract to put in wellness initiatives, but we couldn't do it because it was looked at as a benefit enhancement. So as the fiscal crisis came along, it became evident to everyone that we would have to reopen the contract. And that gave us really the opportunity to revisit some of these initiatives that had really been in our minds for a long, long period of time. And that's really what opened the door to the VBID solution here in Connecticut. So we, as I said, the bargaining was dragging on. We finally reached an agreement, and it was in the context of a extreme amount of agita in the state of Connecticut. The negotiators were being followed out of the negotiating rooms by cameramen, and we were on TV, and what's the progress? And the governor noticed 7,000 state employee layoffs. So while I wish we had had time to do this as Group Health did it in a more collaborative manner, we really just kind of walked over to the deep end of the pool and jumped in. And so after open enrollment, where we had already costed out the agreement and sent it up to the Connecticut General Assembly to show them that we in fact had come up with $2 billion worth of savings, we had assumed a 50% enrollment in the health enhancement program, which of course was predicated on 50% of the people paying the $1,200 a year in extra premiums. We opened up open enrollment, and much to our surprise, when open enrollment closed, 51,000 people showed up, and we had 97 people in the health enhancement program. So we know we're not going to get those savings, and in the infinite wisdom of the negotiators and the costers, we're looking at $100 million in VBID savings in 9 months. Now, that's probably unachievable when we looked at our, based on what everybody else here said today. But when we looked at it, we thought we could move the marker, maybe 20 million, even with the increased utilization of services. But that's what we are up against. So our challenges going forward are to have our carriers track the data of the enrollees to assess their compliance, because we have a contract. Everybody signs a contract. And in June of 2012, if you haven't lived up to their contract, you're out. You're out of the health enhancement program, and you go back to paying $100 a month. Now, you have an appeal. You can go to the Healthcare Cost Containment Committee and say why you weren't able to do it, and well, if it was because of scheduling reasons, your appeal will be granted. And there's also redemption within our program. If you are thrown out and you go get your colonoscopy, we're going to let you back in. So it's really going to be a program where we're going to have a very, very, very high enrollment rate for the next couple of years. So what do we do with this? We have to track the healthcare utilization and the costs, obviously, to something. We don't really have a control group because I'm still trying to find the 2,000 people that didn't sign up. So we're really going to have to look back at our data over the last 3 years and look at our level of screenings, and obviously they're going to go up, and try to track our drug adherence, and also to wander into an area that we did raise in negotiations and had a lot of discussions about, and you've seen it in Teresa's slides and Peggy's slides. What are the indirect savings? What is the value of having healthy employees? And I don't think you can put a price on that. Although we didn't put depression in, as group health did, when we tried to, we just couldn't get it into one of the chronic conditions. We do have a heavy spend on depression-related issues. So we are trying to develop metrics, and Milliman is our plan actuary, and Dave Williams is in the audience, and Dave's going to be a busy man trying to track reduced absenteeism, trying to look at short-term disability reduction in disability retirements, and presenteeism, a concept that is foreign to most people, but I think has a lot of value. We borrowed that from Pitney Bowes in Connecticut. Mike Critelli was their CEO at the time. He put in essentially a diabetes program and costed out the value of presenteeism, coming to work in a more healthy manner. So it's my hope that after we get done applying presenteeism and all of these other indirect matters, we'll come up with $100 million. Other challenges, it's education. We did this so quickly because we were under such pressure to develop a solution to the budget that there was very little education. And we're in the process of doing that education with lunch and learns at the various work sites, with strategies for engagement. State employees are ready to do these things. They just have to do them in a hurry. And we're looking for workplace champions. We're trying to create a buzz around the program. And I'm pretty optimistic that people are going to step forward and embrace this program. One of the things we're really looking forward with, too, is our state employees are of varying classifications. We've got state police officers, correction officers, clerical employees, tax investigators, DEP conservation officers, attorneys general, prosecutors. We've just got about everybody in here. And it's our hope that we can take our data and look to see which of those classifications have the same, more or less of these chronic diseases, so then we can target some of our disease management programs to where these folks are, and then get into the workforce and say, something's wrong here. The way this work is being performed or the way the employees are being asked to perform it is leading to something. And it's our hope that this will be the beginning of a strategy to really look into where the diseases are coming from, if the workplace is causing them, and to begin to address them. So we are very happy about the program. As you can tell, we've got a tiger by the tail, but I'm pleased to report that the two insurers are on board, Anthem and United. Caremark has been very good about cooperating with the prescription drug data, and we shall see what we shall see. So with that, I'll end.
Great. Well, thank you to our panel for a great discussion and great presentations. So I think Peggy really set the frame with her comment that there really is a broad need to try innovations to move to higher value care, and Connecticut and Group Health really have kind of taken her advice, but I think it's really interesting to note that they took it for very different reasons. So Connecticut, took a VBID program coming out of a fiscal crisis and the need to address, high cost of health care. And for Group Health, it was really more looking at how to improve the overall health of their employees. And so I think you see, one of the great promises of VBID is those two different needs can be married up with VBID, and hopefully it can help address both of those priorities. So I'm just going to ask a quick first question while people get out of their chairs. But besides maybe needing to change the name from VBID to something more appealing.
I really like HEP. I think that's a great name.
Well, get HEP is what we said.
HEP, peanut butter and jelly, whatever it is. Are there other regulatory obstacles or other unanticipated hurdles that the audience should be aware of if they're thinking of implementing their own VBID plans?
Well, I think what's important is to get buy-in both from the bottom and the top at the same time. And when Peggy talked about focus groups, it really is important to go down to the employees and ask them, what do you think would help you address some of these problems? I think that is an obstacle, and that can't be overlooked. And you have to get the message from the top that it's important, that it's a culture of health, such as group health, allowing people to make the points to walk around. You have to let them know that you think it's important that they're healthy, and they have to think it's healthy. But regulation, we're a self-funded plan. It's really membership engagement, I think, in moving it forward.
I think the benefits knowledge, as we've talked about, is clearly a key issue. And although our HR people were relentless in their communication, we can never underestimate the potential for misunderstandings and miscommunications. One thing that HR did in our case, which I think was really smart, is they set up a hotline for employees just about this, not about anything else, just about this. So they had any questions, they just call. And I think that helped a lot because it got people the quick answers to their questions. I think the other thing is and I'm going to come back to Kevin's talk, because I found that very interesting just from a behavioral economics perspective. There are many things that are ideal that are difficult to implement. And the idea of advance incentives, the idea of near-term incentives versus rebates. So just to give you an example, we really wanted to, when people come up for a copay for a visit with chronic care, we just wanted to be able to say, welcome, I'm really glad you came in to talk, to see your doctor and talk to you about your diabetes. Go on in. Unfortunately, because of our Byzantine systems and business systems, it was not possible to do that. So what we're doing is we're rebating, and we knew from a behavioral economics perspective that's not the right way to do it. But there was no other way to do it. So I think that the operational business systems need to keep up with the principles, and that's not always easy to do.
Great. Maybe we'll start from the right and move our way over.
I'm Stu Gutterman with Commonwealth Fund. I just wanted to fill in some of the numbers on the physician group practice demonstration that Peggy referred to as a prototype for the ACO model. It was a 5-year demonstration. There were 10 practices there. 8 of them were affiliated with hospitals, 2 not. And by the last 3 years of the demonstration, 5, and then 4 of the sites received bonus payments for saving money relative to their targets. Almost all the sites achieved all of the quality benchmarks, which were set up as a condition for receiving all of the shared savings under that program. So there's some controversy about the measurement and whether the demonstration actually, quote, worked, but those are the numbers.
Thank you.
Please.
Yes, hi, Dave from Millman. I just had, just get your, I have to be taller. Thank you.
You're welcome.
I am standing up. I'm sort of loosely affiliated with the center, and I think your implementation experiences sort of allow me to make a comment, and then also maybe see if you've answered some of the questions that we've had for a long time. In part of our position, as VBID is really, or my position maybe, I think the center would agree that VBID is not a cost-saving intervention. It's basically a more intelligent way of spending whatever health care dollars that you have to spend. And it sounds like what Connecticut did, and I live in Avon, but I don't work for the state yet.
Do you have power yet?
Yes, I do, actually. There have been a few of us who have been sharing experiences of living in a third world state, but which is what it felt like. But it seems like with the help of your actuaries, you more or less established a budget, and you did certain benefit adjustments to try to meet that budget, and then you used VBID principles to try to be smarter in how you spent your benefits. And when I'm done with my that's sort of my comment. When I'm done with my question, which is for David, I'd like just to have you see if you agree with that or not. Then the one with David, one of the interesting things that we've been kicking around, or I've been kicking around, which is, in general, most organizations are not willing from an actuarial perspective, and I work for an actuarial company, so that's probably why I think that way. They're not willing to spend more. Now, it's interesting, in your setting, it's clear you guys were willing to spend more. And when you mentioned your actuarial analysis, I'm just curious how much more per member, not per employee, per member per month you were willing to spend, because I think that's an important thing for us to know. So a comment and then a question.
Do you want to go first on the comment?
They knew, of course, they had their actuaries evaluated.
I'll,
These have an estimate.
let me go first. I think that part of the problem in Connecticut was that there wasn't an investment to spend more, to put in the resources up front. The comptroller's office, which is responsible for implementing this, is understaffed to begin with. They were given 2 more positions. Those people have yet to be hired. You can't do it unless you make the upfront investment. So it's really, to me, somewhat problematic to put a number on something and not fund it. It's, and I know you're a taxpayer in Connecticut, so. But I think that's an important point to make. In terms of whether it'll save money, I don't know whether it's going to save money. I think it depends on the counting, on the presenteeism and the absenteeism, and how you really play it out. I think it is a longitudinal thing, quite frankly. So I guess in response to your comment, I'll have to settle for simply being intelligent and not saving money.
But if I could just clarify real quickly, so and maybe you already understood this, but the objective in Connecticut was that if you didn't enter the VBID plan, you would have had an extra $100 a month premium, right? So it would have been $1,200 a year, and the estimates were that people wouldn't adopt the VBID plan at a high rate. So the 97% of people who opted in, I think Kevin would never agree at a first instance that was a likely outcome. So that was, it's not part of the VBID savings, but that was the incentive that was built around that. Is that right?
Yeah, that is right. It was, too successful.
So I'm not sure I can provide the exact precise estimate. I actually know the numbers, but my math is not good enough in my head, and I need a calculator. But I can give you the number a little bit later. I want to say it's about $10 PMPM, but I'm not sure I can verify that until I have a calculator. And I would say that the upfront investments, it was clear, very clear to our CEO at the beginning, this was going to cost money over the short term. Given that our stick, our which was primarily mostly symbolic, to really make sure that we understood with our staff that from the beginning this was two-way directionality, but mostly symbolic, that down the road that this might be a platform. And I'm not sure I totally agree that you could say right off the bat that VBID is not cost savings. I don't know that we know that. I think if you only talk about the pharmacy dropping copays, it's obvious. But I think if we start to get serious around some things that Oregon's doing, I'm not so sure that that's true. And certainly we're leaving it as a null hypothesis in our study.
Please.
Hi, I'm Vanita Pandilio with Henry Ford Health System Health Alliance Plan. My question is regard to enrollment rates and understanding what that means as a level of engagement. So I understand the Connecticut, by having that pretty heavy stick, you've got the 97%, so that's probably one extreme. But then looking at group health, and where there's probably more carrots, it looks like, and like you said, the sticks aren't that strong there, because you really want to incentivize self-motivation, it sounds like. What are you anticipating your enrollment rate to be for the 4 years, and how do you define enrollment? Because I don't believe they had to engage with health coaches or disease management to a high level. And so I'm trying to understand how do you define engagement? And then
Sure.
What is your percentage of engagement that you're anticipating? Because that's what your savings is going to be based off of, correct?
Yeah, good question. I'm sorry, I meant to mention that earlier. So the first year with the kickoff, we got, with that premium, with that level of incentive, we were able to get about 92% of people taking the health risk assessment at $400 offset. Keep in mind that strong leadership, strong local grassroots champion with union support, it's not just about the money. All those things feeding into this were key, plus 4 years of running in with a wellness program. So 90%, and for those that actually, then the second year we actually had to achieve points in addition to the HRA. The HRA is a portal and a necessity, but then the HRA diminishes in value in terms of points over time and becomes less the issue and more the issue of engagement. And so we're getting right now about a little over 80% of people actually achieving their point threshold on a consistent basis, on a year in, year out basis. So far, we're not seeing drops. We're seeing consistency in that. And there's some people who just clearly don't want to participate in the wellness piece, in part because of concerns about privacy. So one of the other challenges in this is being with the employer and the provider of care brings on certain special challenges, and we had to go bend over backwards around confidentiality and privacy issues. And I think we might have done even better had it not been for that unique situation.
And sorry, one other question for anyone in the group. Looking at VBID programs, and if you look at patients when they have a certain degree of complexity, has there been any analysis done by anyone to say that the VBID program works up to a certain threshold, but let's say somebody with 7 comorbidities, they're just giving up on themselves. It's much harder to engage them. They're at a very different level of care versus, let's say, one with 1 or 2 comorbidities. Has there ever been a breakdown in complexity of patient care in the VBID impact?
We're prepared to look at that in our analysis. We actually have a unique situation. We are able to link HR data, for example, and our medical claims data to our actual survey outcomes data. So we know a lot about the people, and that's all, of course, with permission from the participants. But it's too early for us to be able to say that. I think Peggy's earlier point about it's the bundle is important. Mm-hmm. So the importance of good care coordination in a medical home, with this being sort of a facilitator, but by no means, a strong part of intervention for people with multiple complex chronic disease. Keep in mind that copay offsets in 1s and 2s are very modest, but for people with complex chronic disease who are taking 10 meds, this is a lot of money.
Thank you.
I'd just like to comment on that because I think we kind of make assumptions about people, and I think we need to be very careful to learn from the actual experience. So I think that there are techniques now for setting priorities with patients that have a lot of chronic conditions and so forth, and I think that there's hopeful preliminary evidence that even people that are very complicated, if you give them an agenda and if you work out together a plan, that you can actually get positive change. And if you set those priorities right, it really will have a dramatic improvement in health. So I think, this is an incredibly important research agenda, and we need to learn from it, and we need to be careful about are sort of putting ourselves in the shoes of the patient and assuming that we know what they're going to do.
Mr. Weber?
Thanks, everyone, for the great presentations, and David and Robert and Andy, you as well, for taking the sort of leap amidst a lot of uncertainty, I think, as we've all been saying. David, I'm assuming that part of the CEO's motivation for starting this program is for its application to the broader marketplace, that you'll take this to market with your healthcare plan. Question for you. And Robert, I'm interested in whether, because all states are facing the fiscal crisis that you talked about as a motivator, whether other states are looking at your model, and can you identify some other states that are perhaps thinking about this?
Yeah, great question. You're correct. In fact, the motivation was to actually learn from ourselves before we start to inflict anything on our purchasers. I have to say the tipping point is arriving, and so that I'd hope that we would have our trial, all our study done and results out, and then our purchasers would be well informed. But I sense what is more likely to happen is that we will do probably more like a offering with the check and adjust as we go along. I mean, there's a lot of moving parts in this that will obviously be able to change. But yes, the thinking is, and listening very carefully to purchasers, there's clearly a lot of interest. And so we'll do the best we can in trying to provide an interim, I think, some interim offerings.
And I think that many other unions and many other companies are doing a variety of things. It's just hard to know what everyone is doing. I think there's opportunities everywhere. I know District 1199 in New York is doing some exciting things. And Margaret talked about the Oregon group and what they've done with those two plans. And I think it's really a question of having a repository of the best thinking, because I think if you've seen one VBID plan, you've seen one. And you need to tailor it to wherever your population is. So if we have a certain group of workers, those aren't going to be the same group of workers maybe in another municipality or another state. So the more you share the information, the more research there is to apply it and to see what the outcomes are. I think it just informs everybody. So I think that's the point, is just to keep working together and using all the alliances and all the research you can and just keep moving it forward as fast as you can.
I think we have time for two more quick ones. So.
Hi, Kim Jeanette from the Integrated Benefits Institute, and this question's for David. I'm real interested in the absence and presenteeism measurement you used. I think because you had access to the HR data and also health plan or health risk appraisal data that may make a difference. But what sorts of information did you use, and how did you obtain it, the absence and presenteeism? And did you just use the raw measures, or did somebody attempt to monetize and put those values in dollar terms?
Yeah, great questions. We have in our HRA, we have our own HRA that writes into electronic record, and so we have full control of it. We've actually built in the work health interview that's devised by Walter Stewart at Geisinger Health System. We looked at a number of them, and when we shopped a couple around with brokers and also purchasers, and the output in this is percent of FTE loss. So it can be easily monetized, both for presenteeism and absenteeism, and aggregated across. We also, one of the nice things about his scale, which we liked, was that we can attribute the reason you can sort of break out the reasons. So speaking to some of the earlier points around trying to target specific types of illnesses and problems, it gives you a sense as to what is causing that and whether or not it's amenable to healthcare. So does that answer your question? Yeah, good.
Time for one more. Does one of you have a question for Peggy about NCQA? All right then. Go ahead.
That's all right. You want to go? You touched upon this a little bit, but we know that employees are very concerned about confidentiality, and I was just wondering what sort of messages you sent and what you said to folks to assure them that their data was going to be confidential and their health status, wouldn't be shared with the employer.
You tell them what you told.
So I think the most important thing, again, coming back into is engaging the workforce in the process. So there's nothing that builds trust better than communication, and frequent and sincere communication back and forth, I think, did a lot to sort of help to build that. Nonetheless, what we're doing right now is a IRB, or Institutional Review Board, research study, which comes with all of the protections afforded by that process. And we've developed a series of firewalls. Actually, the process, our data use agreements with Colorado, for example, are extremely complicated. In fact, we've had to work very, very closely with them on this process of how to share data, how to connect data, because particularly when you connect human resources data that contains information about people's occupation and income and this sort of thing, it becomes even more sensitive. So overall, so far, we're getting actually pretty good buy-in from employees, but they don't have to agree to link their survey data. So it was asked earlier, is we've actually unbundled the data collection process, so can people opt into different types of data collection, which will still give us valuable information for certain parts of the study, but maybe not get us everything. So we won't have as much data on, for example, the impact of cost sharing stratified by income, as we will about the impact on preventive services or some other thing. But in the communications around confidentiality had come from the Research Institute, not from HR, and we had to go to pains to make sure that they understood that these were very clearly different, along with all the understandings of what an IRB does to protect research information.
And in the ratification document, we simply put in the document itself that all applicable federal, state law would be strictly complied with, and then we told people that if they weren't compliant in the HEP program according to the records of the insurer, that the insurer would simply inform the comptroller's office that they were non-compliant and not tell them the reason why. So if you were non-compliant, you were just reported as non-compliant and dropped out. But if you came forward to get back in, obviously, then we would sort of know.
Right.
But it really wasn't that much of an issue, to be quite frank with you.
Thank you.
Great. Well, that's it for time. Please join me in thanking the panel.